Yeah, thanks for that. So, good afternoon. I'd like to welcome you to this afternoon's Rutland Health and Wellbeing Board meeting. We do have quite a busy agenda for today's meeting, so a couple of practical matters. Could I remind you all, please, to mute your microphone unless you are addressing an item? And could you please raise your virtual hand if you wish to speak at any point in the meeting? And if I do need any assistance or I need a recorded vote or any other procedural matters, I'll refer to Jane from governance. So if you could do that for me, please. And firstly, we'll move over to apologies. Jane, do we have any apologies?
We do, Chair. Apologies have been received from Dawn Godfrey, Strategic Director of Children and Families, Simon Down, the Acting Chief Executive Office of the Police and Crime Commissioner, and Inspector Audrey Danvers from Leicestershire Police.
Thank you for that. Moving on now to the minutes. This is to confirm the minutes of the Rutland Health and Wellbeing Board meeting on the 22nd of June 2021. I'm happy to propose those. Would anybody willing to second the minutes for me, please? Just a hand, which I can't see everyone. So yeah, thanks, John. So a show of hands on screen will suffice to approve the minutes. If I could have a show of hands. Can you see enough, Jane?
That's unanimous, Chair. Thank you.
Thank you. So the minutes are now confirmed. Moving on to the declarations of interest. Are there any declarations of interest to be declared for this afternoon's meeting? I'll take that as a no. So petitions, deputations and questions. So Jane, have we received any petitions, deputations or questions for this afternoon's meeting?
We have indeed, Chair. We have received one deputation, 9 questions with notice and 1 question with short notice. The questions with notice and the deputation have been added to the website and circulated to committee members in advance of the meeting. However, we only have a total of 30 minutes allotted as per Procedure Rule 93. So any questions not disposed of at the end of the 30 minutes shall be answered in writing and reported for information to the next meeting. The total time allowed by the Chair for each deputation, including the response, will be 10 minutes. The total time allowed by the Chair for each question, including the response, will be 5 minutes. And firstly, we have Mrs. Jennifer Fenelon with a deputation, and I will just invite her in. Good afternoon, Mrs. Fenelon. We cannot see or hear you, Mrs. Fenelon.
Yes, I don't know what's happened to the picture.
We can hear you now.
Right. Okay. I will go ahead just with this picture. Something seems to be wrong. This is a deputation. It's the purpose is that it's about the draft Rutland Health and Wellbeing Strategy and the Rutland Place Plan of 22 to 25. We have concerns about the present draft's adequacy to address a subject as large as the health of the whole population of Rutland. We also would expect key issues to be addressed with the full involvement of the public. Context first, the Rutland Health and Social Care Policies Consortium looks at the implementation of policy within Rutland. Publication of a new draft health and wellbeing strategy for the county, coupled with a place-led plan, is therefore a watershed moment. We welcome the fact that the Health and Wellbeing Board decided to amalgamate its statutory requirement for a joint strategic needs assessment and health and wellbeing strategy together with a place-based operational plan. That makes sense. Although today's paper offers a strong vision for future healthcare in Rutland, set out in 5 objectives, we believe that it fails to deliver adequate needs assessment strategy or plan. By way of background, the health needs of the county were assessed in 2018 when the last joint strategic needs assessment was published. Its findings drove the health and wellbeing strategy 2016 to 20, which set targets for improving the health of the community. But the world has moved on dramatically since 2016, so revisions are now overdue. New drivers of change include, at national level, 1, the long-term plan for the NHS 2019, which advocates care closer to home, and plans to reorganise social care published in September 21, together with the all-party report in October 21. At local level, 2, the impact of COVID upon access to services, as well as impacting on the state of the health of the community. 3, the impact of other lifestyle factors, for example, obesity. 4, the impact of UHL reconfiguration on equity of access for Rutland people by moving acute services to the west. 5, housing plans via the Rutland local plan. 6, impact upon health and social care demand from an ageing population. 7, equality. While Rutland people live longer, the fact that much of that time is in poor health or suffering the effects of rural deprivation remains hidden from official indicators. 8, access inequality. Decline of rural public transport and deterioration of access to primary, secondary and tertiary care. 9, shifts in demand for healthcare across borders, especially on the eastern borders. Next, the context and development of a detailed local plan. The following assurances were given in response to public questions to the Adult and Scrutiny Committee on the 9th of September 21. 1, the update of the Joint Needs Assessment. The reply states that extensive assessment of needs has been developed and that further work will be completed from October onwards when the JSNA is reviewed and aligned with the priorities of the PLP. And the needs of Rutland people and how these will be met is at the core of the place-led plan. As the JSNA is statutory and it is a treasure trove of information, it needs to be the basic building block, not added on later. The draft strategy and plan before you today does not show the needs of Rutland population or how they will be met. B is the impact of UHL reconfiguration. The UHL decision-making business case is predicated upon additional community facilities being in place and fully aligned with the UHL key construction milestones in order to mitigate the impact of closing Leicester General. The reply reassured that the place-led plan will set this out, but it does not. C, public involvement in developing plans. Guidance for new integrated care systems stresses the importance of developing services with local people and those who use the services. In quotes, the future consultation on more detailed action plan will be determined through the Health and Wellbeing Board, where the detailed draft plan will first be presented. We have no proposals in the work plan before us. D, cross-boundary issues. Assurance was given that discussions were taking place across boundaries to ensure capacity, but also that in addition, the place-based plan for Rutland will explore what additional services could be provided locally to reduce the number of journeys patients need to make. These reassurances are encouraging, but no detail is given on the services proposed to reduce travel. Lastly, the need for joined up patient records. The reply said that it was expected to have integrated care records by 2024, but that would not enable the transfer of notes in paper form. But the plan remains silent on IT provision. In conclusion, One, we have concerns that the process being used to prepare a local health plan is inadequate to the task of preparing a health plan for the county. Assurances given in answers to public questions at scrutiny that the plan would cover a range of issues have not been fulfilled. Two, we urge that the local plan focus immediately upon two areas that cannot wait. First, ensuring that services in mitigation for the move of Leicester General Services are planned to both shift as much as possible closer to home in Rutland, and where residents have to attend hospital in the east, that they are properly planned and effective pathways and resources put in place. For both shifts, we wish to see adequate capital and revenue funding identified. And two, the myth that there is no inequality or inequity in Rutland needs to be dispelled, especially around transportation inequity and the impact on the elderly. Three, research was planned with the publication of the JSNA in 2018 into Rutland's hidden rural social deprivation. We urge that research be completed and incorporated into the local plan. Four, we believe that the current proposals to incorporate public input into the proposal are inadequate and should be revised. The public is keen to contribute. Five, and lastly, we ask the Health and Wellbeing Board to defer endorsing the overall vision, principles, priorities and action areas set out in the draft strategy and plan as presented today until the JSNA, which underpins the plan, is complete and there is a clear description of how the goals set out in the vision will be implemented via the strategy and via the place-based plan. Thank you.
Thank you, Mrs. Fenelon. So that deputation has been received. Do any members of the board have any questions they would like to put to Mrs. Fenelon? I don't see any hands, so thank you again, Mrs. Fenelon. Moving on, Jane, who do we have next?
We now have Mr. Ron Simpson, and I will bring him into the meeting with a question. Good afternoon, Mr. Simpson.
Good afternoon. Can you hear me okay?
Yes, we can hear you.
Okay. Good afternoon, members. Can the Rutland Health and Wellbeing Board advise on what steps are being taken to integrate the county's public transport and environmental strategies with its health plan for Rutland? More specifically, what new public and community transport initiatives will underpin the identified need for regular public travel to the plan's medical centres, both in and out of the county? Thank you.
Thank you, Mr. Simpson, for that question. I shall respond from the chair. Thank you for reminding us of this issue, which we are, of course, fully aware of. I shall continue to work with my colleagues on Cabinet and within the wider council membership and officers to seek solutions to the transport and environmental issues and opportunities. As you already know, I am an open book, and I look forward to hearing any and all constructive suggestions on these issues from anyone who wishes to contribute. I am aware particularly of the community work that you yourself have accomplished, particularly in Uppingham, and I would be delighted to arrange a meeting with you to hear your suggestions, acting either individually or as a representative of CPRE. You have my number. Mr. Simpson, do you have a follow-up question?
Thank you, Chair. I will respond in time.
Thank you. So, Jane, who's next?
Thank you, Mr. Simpson. We now have Mr. Niebel with a question, and I will bring him into the meeting. Good afternoon, Mr. Niebel.
Good afternoon. I have two questions, actually. My first question is as follows. Priority 4 is a very important element of the plan, given so many Rutland residents access healthcare in other council areas and health systems. So it's good to see that engagement with neighbouring health and care systems whose services are actively used by Rutland residents is recognised as necessary. Can the Health and Wellbeing Board indicate what form of permanent and resilient joint working arrangement is being considered with neighbouring health and care systems to create and agree how cross-border referrals and access to care are to be agreed and managed?
Yes, I shall give a brief response from the chair. These arrangements are still under development and will be reported back to this board in due course. They will, of course, be public meetings. I believe you may have a supplementary.
I do indeed, Chair. Thank you for that. Will the Health and Wellbeing Board be ensuring it is well cited on the place-based plans of neighbouring health and care systems? And is it taking steps to enter into dialogue with these bodies to ensure congruency of planning?
The answer from the chair is yes. I believe you have a second question.
I do indeed. As it is now proposed that there will be two bodies within an overall integrated care system, namely an integrated care board, which seems to be a successor for the CCG, and an integrated care partnership, which seems to be the way in which health and council management will be integrated. Can the Health and Wellbeing Board explain where and its health and its plan, place-based plans, sit within this structure? So apologies for stumbling that. Can the Health and Wellbeing Board explain where it and its health-based plan sit within this structure?
Thank you, Mr. Niebler. I'm not sure whether you struggled or partly answered your own question, but either way, I'll respond from the chair. Officers will provide a written response on detail. However, from the chair, I can indicate the current direction of travel, which is that this council is expected at this point in time to be represented on the ICB by one senior officer, and that the ICP is expected at this time to likely have equal representation from each of the health and wellbeing boards in Leicester, Leicestershire and Rutland. It should be emphasised that Rutland will have the same level of representation as Leicester and as Leicestershire on both of these boards, despite us only being approximately 3% of the total population of that area. One note of caution is that the terms of reference continue to be developed, but that is the direction of travel, and I hope that is helpful. Officers will respond in writing with further detail.
Thank you, Chair. I'm grateful for that and look forward to those further responses. I recognise the disparity in size between the Rutland population and that of its neighbouring larger partners within LLR, and hope that the council will be striving, as always, to make sure that the voice of Rutland isn't diminished simply by our size.
Thank you. I'll take that as effectively a supplementary question and say yes again.
Thank you very much.
So who's next, Jane?
Thank you, Chair. We now have Mrs. Elaine Woodhead with a question, and I will promote her in. Good afternoon, Mrs. Woodhead. Please go ahead with your question.
Hello, good afternoon, everybody, and thank you. My question actually overlaps a little bit with Ron Simpson's. As Vice Chair of St John and St Anne, a large Rutland-based almshouse charity, I would like to know how you intend to meet the health needs of our residents and other elderly people who can't afford cars without subjecting them to long journeys to hospital appointments they find it extremely difficult to navigate and which cause significant distress. Thank you.
Thank you. I'll answer from the chair, if I may. So one of the core ambitions of the changes to health and wellbeing is the principle of bringing care closer to home. We will continue to look for ways to reduce the need for residents to travel long distances, either for diagnostics or for care, wherever appropriate. However, we must acknowledge that we live in a rural location. That does not mean we should willingly accept unnecessary disadvantage to our residents. And as I say, we will continue to look for appropriate opportunities for care closer to home. But it does mean we need to be mindful that travel to services some distance away will be inevitable in some cases. Other than that, I refer to my answer to Mr. Simpson, as you suggested.
Yeah. Okay.
Do you have a supplementary?
No, thank you very much.
Jane?
Thank you, Chair. We next have Mrs. Mary Gallagher with a question, and I will promote her through. Good afternoon, Mrs. Gallagher.
Hello, can you hear me?
Yes, we can hear you. Please go ahead.
Thank you. Active and retired service personnel are a large and important part of Rutland. Adult and Health Scrutiny was asked if it was satisfied that enough resources were being sought to meet their needs, especially mental health and welfare. In reply, Scrutiny pointed to the Better Care Fund as sufficient. My question is, could you please supply us with your evidence supporting the conclusion that the Better Care Fund could be used for and would be adequate to meet the considerable additional needs of the military?
Thank you for that. Could I please ask you a question of clarification?
Yes.
Are you referring to the reply to the question by Mr. Miles Williamson Noble at the last meeting of the Rutland Health and Wellbeing Board, or are you referring to another meeting or another question?
I'm referring to the Scrutiny Board, which I think was on the 9th of September, from Miles Williamson Noble.
Okay. I've looked into formal responses that I've been able to find. I have not been able to reference any comments specifically suggesting that the Better Care Fund would be the only resource to address the needs of the military or their families, nor would I expect it to do so.
Thank you.
Jane?
Thank you, Chair. We now have Mrs. Claire Henry, MBE, with a question, and I will promote her through. Good afternoon, Mrs. Henry.
Thank you very much. And thank you to the board for allowing me to ask a question. As one of the directors of Dying Matters in Rutland, I'd like to ask the Health and Wellbeing Board the following question. Dying Matters in Rutland is an initiative led by the Lord Lieutenant, which supports Rutland people to have the best possible end-of-life care. We are associated with a wide range of professionals and voluntary organisations who will be delighted to work with you in planning and developing end-of-life care for Rutland. Could you please tell us how and when we can contribute to the proposals to the Rutland Health Plan before it is finalised? Thank you.
Yes, thanks for that question. I am aware of the initiative, which I applaud. I am also aware that Sarah leads on this. I was made aware well before the project began, and I invited her to a meeting where we discussed the importance of the project enhancing our other health and wellbeing services and initiatives, and how we should develop a symbiotic relationship. The Rutland conversation attracted over 500 comments on health and wellbeing, which have helped to inform the draft plan. You and your colleagues will have been able to take part in that. There is also a proposed consultation period if this board agrees to proceed, and you should most definitely take part in that, which means your contribution will be logged and formally acknowledged. However, on a more fundamental level, I would urge you to simply come forward and talk. Everyone on this board has the same ambitions for the care of our residents in Rutland, but I am aware that not everybody is fully appreciative of how approachable we are individually and collectively. And so I would respectfully suggest, now that you are aware of this, that going forward, it may be more effective to come forward directly with suggestions and comments rather than perhaps submitting questions about how to make those comments. For the avoidance of doubt, my contact details are a matter of public record, and I normally meet Sarah in another capacity approximately twice a month, at which time we do chat about the future and health, and I would always be happy to be told that you need a meeting. At such a meeting, we could discuss further how your project can help work with us and what specialised knowledge you can bring to us to help us to refine the plan. However, it is important that you also use the formal consultation period to ensure your comments and suggestions are logged and acknowledged. Do you have a supplementary?
No, thank you.
Thank you. Jane?
Thank you, Chair. We now have Mr. Clifford Bacon with a question, and I must point out, Mr. Bacon, we are down to the last 5 minutes for this section. Good afternoon, Mr. Bacon.
Good afternoon. Can you hear me?
We can hear you, Mr. Bacon. Please go ahead with your question.
Thank you very much. This is a question concerning healthcare across borders. And I would like to ask if we can be assured that the joint ICS planning will be carried out with the degree of granularity or detail that includes estimated numbers of patients and the shifts of funding which are involved. Could you assure us of that, please? Thank you.
Thank you. My response is, given the complexity and the degree to which that refers to health services directly, a written response will be provided, distributed, and attached to the minutes of this meeting.
Thank you, Chair. I think we may have time for just one more question. That is from Mrs. Fenelon, and I will bring her back into the meeting. Good afternoon, Mrs. Fenelon. We can't hear or see you, Mrs. Fenelon. Are you still there?
Sorry, right. Shall I try and, can you hear me now?
We can hear you now, Mrs. Fenelon. Please go ahead with your
Okay,
question.
I will speak quickly because I'm conscious of time. UHL reconfiguration is predicated upon additional community facilities being provided and in place before reconfiguration and aligned with UHL key construction milestones. Reassurance was given by scrutiny that the place-based plan would set this out. Sadly, these vital plans are not within the draft plan. Now that Rutland Health and Wellbeing Board has taken on responsibility for overseeing these shifts, as well as provision of secondary and tertiary care for those who cannot travel to Glenfield and LRI, would you please give details of the project plans to, and I will shorten this, A, evaluate which inpatient and outpatient services should be relocated in Rutland, and the capital and revenue necessary, including for IT, and B, evaluate the likely numbers of inpatients and outpatients who will have to transfer to Peterborough and Kettering for secondary care, and to Addenbrooke's and Oxford and Nottingham for tertiary care, and your assessment of the revenue and capital that will require. Thank you.
Thank you for your question. A written response will be prepared, supplied to you, distributed, and attached to the minutes of this meeting. I suspect are we out of time, Jane, or do we have one more?
We could possibly squeeze in one more. That is Mrs. Leah Toseland. And let me just bring her in. Hello, Mrs. Toseland. Good afternoon.
Hello, has that worked?
Yes. Good afternoon, Mrs. Toseland. We can hear you. Please go ahead with your question.
How will patients be employed in the process of co-production of services in the short time available?
A written response will be provided, distributed and appended to the minutes of this meeting. Would you like to move on to question 2?
Yes, please. Healthwatch Rutland is a signatory to the draft plan presented and therefore can no longer be able to independently represent the views of the public. How will public views be gathered during the proposed consultation?
Thank you. We will supply a written response to that. However, my response from the chair is that I do not agree that they can no longer act independently to represent the views of the public, and I would expect them to continue to consult with the public. That is their role. Jane, I think we're out of time.
We are indeed, Chair. We have further questions from Mr. Tushin and from Mr. Ross, but written responses will be provided.
Yeah, thank you for that. So I believe we're now on, Jane, to item 5, which is a report and presentation on the Leicestershire and Rutland Learning Disability and Autism 3-year plan. So do we have a presentation?
Yes, and we have Mr. David Williams here to present.
Lovely. Thank you, Jane. Are you sharing the screen or would you like me to, Jane?
It's entirely up to you. I can, if you want to talk through it, I can.
I've got it. So it
Yep.
should be coming up now. There we go.
Thank you.
That visible? Brilliant.
Yes.
Lovely.
Perfect. Perfect.
Okay, thank you all. Thank you very much. So I'm David Williams. I'm Director of Strategy and Business Development for Leicestershire Partnership NHS Trust. I also work across Leicester, Leicestershire and Rutland, supporting and leading the work that we're doing around what's called the Transforming Care programme, which is a national programme about supporting people with learning disability and or autism to come out of hospital and to live in communities. I've just got a total of 9 slides, including the one that you've got here, just outlining our 3-year roadmap, and then I'm happy to pick up questions. I think the key thing that I would just flag to you all to hold in your mind about how we support people with a learning disability and autism in Rutland, but also across the Leicestershire County and Leicester City, is that at the moment, if you have a learning disability or autism, you will probably have a life that will come to an end at about 59 years old. And we've got some inequalities and some ways that we want to tackle the services in order to improve outcomes for everybody. And that's taken us on to, first of all, identifying really clear vision about what we'd look. What we've all agreed is that all people with a learning disability and or autism have the fundamental right to live fulfilling lives within their strategies, and the things we're putting in place are all about enabling people to live that fulfilling. So we've done quite a bit of work about improving our performance and looking at the ways we go, and we are nationally monitored on the number of people with a learning disability who are. We've really reduced the numbers of adults that have been. You'll see things on the local news. Norfolk, there was a safeguarding review about care of people in a recent. was another recent one. And our aim is actually to get people to live in the community. So we've improved our performance. We've got additional national funding in. We've been supported by national policy shifts, and actually across LLR, we've brought people together so that we're doing joined up working. So there is some really good working between ourselves and Rutland, social services, the way we're working together, the things we're doing in order to improve. What we've said is we need to do a little bit more. So we've set ourselves the aims and objectives in improving well-being of people with learning disabilities and making things far more person-centered, reducing the health inequality, improving quality, increasing the focus on autism, especially for those who are over 40, improving the ways that our pathways work, reducing the number of admissions that people need to go into hospital, more services in the community, early intervention, and crisis avoidance is about making sure that we look early enough to avoid people going into crisis, to avoid that admission. So we've been working through those things with everybody, and to do that, we've had some really good feedback. I'll leave those couple of those quotes back up there at the moment, but a real positive sign on where we're going in actually supporting people. On the left-hand quote, it just talks there about how somebody wanted to give us a big thank you for organising special vaccination sessions. And so we've been through COVID vaccination sessions by having specific learning disability clinics. This individual here says that my daughter would have been unable to cope with going that they went to. Things were all really organised, and everyone we encountered was really helpful and friendly. So we've provided longer appointment times, and we've allowed people to bring carers or family members with them. I think the significance of this is it's now going on, and we're getting more people with a learning disability or autism taking up flu vaccinations and other of their vaccinations, which historically they couldn't do. That will improve wellbeing. And then somebody else just came back to us to say they wanted to share the good news about all of the work that together with local authorities and the NHS, we've all done on bringing together buildings and dedicated places for individuals to live in. And they were reflecting there on how much of a difference that we really will have made. So there's some of the positive sides of stuff. We feed that into a 3-year plan. I wasn't going to go through the 3-year plan in detail in everything that's, you can see the elements of how we're bringing everything together about supporting things. What we've said we're going to do for this year is have a real good focus on increasing the amount of work we do co-production with learning disability and autism, working clearly on admission avoidance for both children, young people and adults. We've got an integrated team working, so together social workers are working with LPT, so my trust's provider services, the frontline services, but also the CCG commissioners to do joint working to get everything together. Annual health checks are something that primary care offer, and they provide a regular opportunity to support people and identify things early. And we work with primary care to help support, develop and manage that. Providing more community and inpatient support for people with a learning disability and autism. And then LEADER, that penultimate bullet point, is learning from deaths reviews. And when we do have an individual with a learning disability or autism who does die in LLR, we do a review of everything that happened in terms of their health and care in order to make sure that we can learn from it. So implementing the learning from that's there, and then feeding in the better support for our forensic cohort and supporting people. I think the slides left, specialist autism team is something that we're absolutely focusing on. This brings in our work that we link in with education schools and other support that goes through. Our community forensic service is there about reducing serious reoffending, our discharge, live safe. In year 1, we're looking at integrated working. In year 2, we're looking at no delays in transfers of care, really building things forward with a better, stronger workforce. And in year 3, we'll have delivered the things that put us there to be a person-centered. And the strap line we've kind of worked about is our goal is about making LLR fit. It means focused on the needs of our people. I is for the integrated team, and the T is targeted on where we can make the most difference. So that's our summary of how we're coming together. We wanted to bring our plan with you to share it today. Happy to pick up any key questions and ways of working things through. But the focus for all of us is turning around and saying, how can we address and improve the inequalities that people with a learning disability and autism are facing. And we believe our 3-year plan will take that forward and will really tackle the way we're working. So I hope that provides a good update. I'll stop sharing my screen and happy to pick up any questions.
Thank you, Mr. Williams. Are there any questions or comments from the panel? David Wilby, I can see you, but not your virtual hand.
Okay, thank you very much, David. I thought that was an excellent presentation, and certainly the best presentation done on the screen. You set out very clearly what you intended to do, gave the steps that you were going to do, and gave us an idea of what to expect at the end of that period. And to be honest, it was an exemplar of what perhaps some of our other papers should have. You know, clear pathway, clear indication, short, punchy sentences, and ones that are easily digestible. I thought that was really cracking, and I know that my team in education in Rutland are working closely with your folks in trying to improve the early help and taking it right the way through. And with the way that you've just explained it, I'm absolutely convinced now that we're on the right road, and with that sort of help, we're going to get some really good results. Thank you.
Thanks, David. I'm not sure who put their hand up first, so I'm going to go to Janet Underwood.
Thank you, Chair. As with Mr. Wilby, I thought this was an excellent presentation, and I never cease to be amazed with the transformations that LPT are making in regards to learning disabilities, mental health care, etc. Do have one question, which is really predicated on the feedback we as Healthwatch Rutland received from people with learning disabilities when we were engaging with them about what their needs and wants are for place-based care. We were consistently told that they want work opportunities here in the county, and they also want social activities that are much more accessible. I couldn't see any reference to this more social and economic aspect in your presentation, and I'm just wondering if it's featuring on your radar, so to speak, or whether it's something that is not your department, or quite what.
Thank you, Janet. I wonder, Chair, whether we could take Dr. Hilary Fox's question together, because there might be a bit of then coming back and talking about what we're doing in Rutland community and ways of working, and I could potentially link the two together. And Kim, you might want to add something on some of that as well, if that's okay.
So should we be having Dr. Fox join in at this point?
Is that okay?
Yeah.
Thank you. Thank you. Excellent presentation. My question is really in reference to some of the earlier deputations and questions. Rutland Health Primary Care Network, we have patients who live across the borders, including a residential facility for people with learning disability, which is in Northamptonshire. Have you and are you as LPT engaging with the local authorities in those areas, in our surrounding areas, Lincolnshire and Northamptonshire, to make sure that this is a uniform offer for all our learning disability patients?
Okay, great, thank you. So, Hilary, I think I'll respond to yours first, and then come to you, Janet. Hilary, absolutely. So in looking at what everybody's doing and where a Rutland service user is part of the work that we must do across LLR. So whether if they are a Rutland service user who is in hospital in a Lincolnshire hospital or in a Northamptonshire hospital, actually making sure that there are 8 weekly checks, support, conversations going on, that is a core function of it. Kim and I were in a meeting earlier this morning where we were looking and monitoring the performance of that to make sure it's happening. I suppose on a personal level, I have an easier focus into Northamptonshire than the others because I also do some days a week working in the Northamptonshire NHFT, Northamptonshire Healthcare NHS Foundation Trust. So again, make those conversations through. But the key focus is if people are somewhere else outside of LLR for their care, is that care progressing well? Do we know what's going on? And what are the opportunities for bringing them either straight back into the community or back into one of the LPT hospitals, depending on where their need is. So we do focus that through. Janet, for your question around engagement and services, the fulfilling lives, I think, is the most important thing for us to build as we take a vision forward and a way of supporting people. For people who do not need to be in hospital, they do not get a fulfilling life in hospital. So when, and the quote that I didn't read all of it out was about the mother of a service user who'd come out of hospital after many, many years and could now go down to the shops, could start living their lives, could start attending things. And the amazing difference that that's made to their ability to engage and have services and ways forward was huge. And then in the detail of specific services and other things, then the local authority are probably more of an expert around some of the other bits that might be available in Rutland. We might need to come back to you, but absolutely focused on saying, how can we get people to contribute and work these things through? And the other bit I'd say is, I mean, LPT, but anybody can do this, is championing support and fulfilling employment for people with a learning disability. There are people with a learning disability who work directly for LPT, and there are people with a learning disability who work for many other employers, and championing that across Rutland was a good thing to do, and that will help support people as well. So I hope that gives you a broad idea, and I don't know the detail of everything in there for Rutland.
Sorry, can you hear me?
Yes, Kim.
Sorry.
Yeah.
Thank you, Chair. It might be worth me just adding a little bit there, Janet, to give you a bit of a rounded idea, more of an idea of what Rutland do. So where we're working together with our system approach with David and LLR, across LLR, we're also looking at that early intervention and prevention work about actually how we support people to stay well, and about how that prevents people going into hospital. So it's not just about discharges from hospital, it's about how we keep people well enough so they're not having to go into hospital. And we can do that by the support, either that's commissioned, support through social care, or through the universal offer, and that's through children's and adults. So for an example, I was on a meeting the other day with a job coach for children's that was looking about how we support people having those aspirations to be in work, to be fulfilled in their lives. But also in Rutland, in adults, we have an employment officer. So we're linking in about how we can get people into work and and out of services primarily, you know, that they can have independent lives. And if they have commission services, they always have choice about how they want to use those services, access those services. So, for instance, direct payments could be used to buy in their own support, and that could be community support, and that builds a market as well, Janet, around having new providers, which we've actually seen over kind of COVID and over the pandemic, new providers starting up within the community, both Rutland and kind of under the borders of like Melton, Mowbray, of where people are wanting to do different things outside of traditional services. So there's work going on there, and I think that kind of and from a co-production point of view, we tie in with David on. There's many groups that Transforming Care are involved in. I think about 29 work streams, aren't there, David? One of those is Every Voice Counts, and that is about the co-production and about getting the voice. And Rutland are a partner in that work as well, about how we don't just get the views of the few, but we try and the task is how we widen that out and get the views of the many within that. If you do need to know any more, please come back to me.
Thanks for that, Kim. Does anyone else have anything to ask or comment on? If not, I have a question. I'm not seeing anyone at the moment. So I'm a member of the Leicestershire and Rutland Safeguarding Adults Board, and we did take a report some months ago about the increased incidence of adults with learning difficulties who were not receiving treatment because they had a DNR, and that became a safeguarding issue, which resulted in NHS England writing to all GPs saying that a learning disability is not a fatal condition. Could you give me some confirmation that you have had feedback from the Safeguarding Board and that you have taken that into account and that something is being done in Leicester, Leicestershire and Rutland to prevent inappropriate DNRs being written out for people with learning disabilities?
Yeah, thank you. Really important, and thank you very much for raising it. Much appreciated. Yes, I can confirm that we've had feedback, and yes, I can confirm that action's been taken. On a number of occasions, we have shared across the health and care system the NHSE update that having a learning disability is not a reason on its own for having a do not attempt resuscitation to be in place. We then also continue to have a look, should anybody with a learning disability or autism die, it's an additional thing that we do in the review of that to understand whether there was anything there, was there a DNR in place, did it make a difference, where was it going? So we've been proactive and ensuring that it is not used where it shouldn't be used, and we've been reactive by looking at any deaths to understand that and flag things through.
Thank you, that's very reassuring. Does anyone have anything else on this paper? I don't see anything, so thank you very much for that update, which, as everyone has said, was really well presented, so thank you for that. We'll move on to the next item, which is the purpose, principles and priorities of the integrated care system. And I believe that Sarah Prima, Executive Director of Strategy and Planning at LLR City Clinical, that's quite a good title, will lead us through this one. I could be wrong. Sarah?
Councillor Walters, if I may, Sarah is on leave this week, so has asked me to step in and present. Thank you, if I may. Thank you very much. Good afternoon, my name is Rachna Vyas. I'm the Executive Director of Integration and Transformation for the 3 CCGs across Leicester, Leicestershire and Rutland. My colleague Sarah Prima and actually David Williams as our LPT colleague, along with Mark Whiteman and various other colleagues across health, social care and the voluntary sector over the course of the last couple of months have been drafting the purpose, principles and the vision of the LLR RCS, and that's what we are here to present to you today. So if you just bear with me, Chair, I'd like to just share my screen with a few slides, which I have to say are not as smart and as polished as David's. So that's a learning point for us. Right, Chair, if you could just give me the nod that you can see those.
Yeah, sure can.
Brilliant, thank you. So just in terms of background then, so these were put together through a, let's just minimize this. Put together through a set of colleagues across the system, as I said, through a series of workshops and task and finish groups, and have been through all organisations across Leicester, Leicestershire and Rutland thus far. At the final workshop, people were asked to provide final comments and feedbacks, and that's what has formed this kind of final draft, and we're here to ask for approval effectively for this particular document. So we have tried to keep this as simple as only a corporate body can. So let's get that on the table first. So we're trying to put forward a set of vision and principles which will actually enable us to do what we've just described. And I'm really pleased that I've gone after David, because actually I'm going to draw on examples of our learning disabilities programme just to bring this to life a little bit. So the purpose of the integrated care system as it is to work together for everyone in Leicester, Leicestershire and Rutland to have healthy and fulfilling lives. So healthy, which is effectively the NHS's part in this, and fulfilling, which takes into account something which Janet talked about earlier, which is actually what are those wider determinants of that we know that will impact on somebody's life for it to be healthy and fulfilling. So what wider determinants of health do we need to take into account, like the economics example that Janet gave? In terms of principles, again, we started off with a long list of something like 40 principles, and we've come down to this one big principle with decisions that sit underneath it. So we're talking about making sure that everything is centered on the people and communities of LLR, and we genuinely mean not communities based on any lines drawn on a map, but genuine communities where we found communities of people. We work together with respect, trust, openness, and common purpose to do the following things. So equitable access to health and care, which I know is very high on the agenda here today and has been referenced many times already. Decisions that enable great care for our residents. Services that are convenient and easy for our residents to access. Again, something that we've been working with our Rutland Task and Finish group for quite some time. Integrated services through co-production and partnership with our residents. Making LLR health and care organisations, so regardless of which NHS or care or local authority badge you wear, we want it to be a great place to work and volunteer, and making sure we use the combined resources that we've got to deliver the very best value for money whilst we are supporting our local economy and making sure that we've got sustainable services from an environmental point of view. Now, those all seem like the usual things that big corporate bodies will normally say when it comes to principles. But actually, the example that David's just given you from a learning disability point of view, the people that are working on that programme, whilst under the leadership of LPT, they are people who sit in my team. There are people that sit in John Morley's team over in Rutland County Council from that colleague point of view. There are people who are actual recipients of the service. So we are already working in this way to deliver these principles, to deliver the overall purpose of the ICS. So this is not something which is kind of motherhood and apple pie, which might happen in the future. We are living and breathing this as we go through the course of this year. Now, to break that down in terms of what we're actually going to do, so it's lovely that we're working in that way from a principle perspective, but what are we actually going to do? So what we want to do is focus on 4 areas, which we've already referenced through some of the things that you've heard already today, and some of the things that you will hear when we start talking about the plan. We're talking about the best start in life. So we know that with those first 1001 days of life will have a real impact on what happens to that child in adulthood, and often quite the next generation that comes following that child. So a real focus on what do we do to ensure the best start in life across the entirety of this place. The second one is, how do we make sure that people stay healthy and well? Now, this is to do with some of the environmental and planning issues that we have in Rutland, how we make sure people are making healthy choices to maintain well-being in its widest sense, so physical health and mental health, and independence in their communities, which is such a strong theme, particularly when we're talking to our Rutland residents, that we want independence, and we want to make sure we keep things in our own communities. Third thing is living and supported well. So making sure that people who do have multiple either long-term conditions or who are frail and can't manage their health necessarily as independently as they want to, how do we encourage them and help them to be as independent as can be? So not doing things to people or for people, but doing things with people. And how do we enable that across health and care in the plethora of services that we provide in an integrated manner already? And then finally, dying well. As one of the questions was earlier, how do we make sure that we are really making sure that people have a personalised experience when they come to the end of their lives? So this is really the last 1001 days of people's lives, and making sure carers and families have got the right support wherever they want in their communities, and so on and so forth. So we've tried to keep it fairly simple with those 4 big areas, but you can imagine there's a plethora of work, which I think David has really just told us all about. So if you take LD, we are working through this life course for all of those patients who are on those learning disability pathways to make sure that we can start to live and breathe some of these things. Now, of course, whilst those life course priorities are very important, we have some very practical things that we need to do in the here and now, and we've termed these operational priorities for the ICS. So we know we need to work together across health and local authority to deliver COVID vaccination programme, as well as winter flu, and making sure we've got the maximum uptake. We're in quite a unique position this year where we are not 100% sure about what is going to hit us for winter. Normally we have models and we have best and worst case scenarios. And this year we're already at our worst case scenario effectively in terms of numbers. And therefore we will make sure that we have sufficient modelling going forward about what is actually going to happen over the course of the next couple of months. Now, we know our best chance to enable that to happen for this system and to keep our people safe is to make sure people are vaccinated and to make sure our flu uptake across all of our cohorts is at its maximum to ensure that we can keep people safe. The second big priority locally is to recover services in all sectors. So this comes back to our social care services, it comes back to our elective care services, and we need to make sure we are communicating with our residents as we do so. Every service that we have across health and care at the moment has some form of backlog, which hasn't necessarily been seen in as we would have because of the pandemic. So we need to recover those services as quickly as we can in partnership with our residents. Third thing is the changes to the University Hospital Leicester programme that we've got from a reconfiguration point of view, and the step up to great mental health services to make sure we've got the localised delivery, of course, that we've talked about already today, both in the deputations that we've heard and some of the consultations that we've had previously with our Rutland residents. And finally, really working together across the system, so across health and care systems and with our communities to transform access, particularly, we've heard many times in these discussions, access to primary care, access to urgent care, access to making sure that chronic conditions are dealt with from a health and social care perspective on an integrated footprint, and of course our mental health services. So some real big ticket items there in terms of making sure that we can deliver the operational priorities, which give us some space to deliver then the transformation priorities that we know we've got to deliver. Now, as I said, all of that is you know, it's a huge amount of work that we have got to do. We recognise that we cannot do it alone across health. We cannot do it alone in social care, and we certainly can't do it without the support of our citizens in the way that we have tried to set up the programme. So, Chair, I'll pause there for any questions, and that's really where we are with this paper.
Thank you, Rachna. Do we have any questions or comments on this paper, please? I am seeing no one raising their virtual hands.
No, it looks all clear.
It looks all. Rachna, the last part of that, and I'll just find it myself, the operational priorities. So how often do we think we're going to renew those? Because they're obviously very now-centric, aren't they?
They are, Chair. I mean, I think it's going to take, well, I think that they're going to be quite different in each of them. For example, we know the reconfiguration programme is on a long-term footprint, for example, but we know that the recovery of elective care service is something that we are living and breathing on a day-to-day basis now. So you're absolutely right. We expect to have to refresh them as agilely as we need to, if I may suggest so. You know, we could stick to arbitrary deadlines like every financial year and so on and so forth. But you know, if we've delivered something, we need to move on and find out what the next priority is and get on with it, in my opinion. But there will be, of course, a statutory requirement to do a regular refresh, probably on an annual basis. But my suggestion thus far has been that we be as agile as possible with this to make sure we are delivering the right things with the right focus and the right pace behind the transformations.
Thanks, Rachna. I think you're right. It should be a living, breathing document, not a static document. But Mike, you wanted to come in.
Yeah, thank you, Chair. If only because I can't stand the silence, really. I suppose the thing is with David's presentation and then Rachna's, and I know we'll come on to it with the health and wellbeing strategy. In isolation, I suppose I'm finding it difficult to ask a question because you can listen to it and go, yeah, actually that's fine, as they have been. There is that general point, I suppose, is all in well, certainly in my mind, and I guess it's in all people's minds, isn't it, about how all these different parts of the jigsaw fit together, which isn't it's not a question to pose now, but I guess once we've done all the presentations, either at this meeting or a future one, this, to my mind, the key question is how does this all fit together? Because individually it makes perfect sense.
Chair, may I come back just very quickly on that? So, Mike, that's our problem, isn't it? If that is the perennial issue that we are dealing with, and I think the more and more that we are working together. So the presentation that we had earlier, and I'll keep referring to it from David, you saw that was public health, it was social care, and it was our Health Watch colleagues all working together to make sure that we've got the right service provision. Now that in itself, when you look at learning disabilities in isolation, all looks lovely, but actually nothing happens from a learning disability perspective without touching primary care or acute care or public, so that's in our gift to make sure we've knitted all that together. And that's certainly been the challenge to the teams thus far, is making sure that we've done that check and challenge, including all of the cross-border work that we talked about earlier.
Thanks, Rachna. I'm still not seeing any hands up. So does anyone wish to raise anything which would prevent this board from approving this paper that's been put to us? This is John, you wanted to say something? Hopefully not to do what I've just said.
I've got to say something. Chair, there's nothing to disagree with here as far as I can see. So we endorse, I say we, I endorse it personally, fully. Thank you, Rachna.
Right, I'll have a final check through the names list. So thank you, Rachna. I take it then that this board does endorse those priorities and principles.
Thank you, Chair.
Thank you for that. I'll just find out where we are. So we're on to the Health Inequalities Framework. Is that you, Rachna, or have I got it wrong again?
No, there's my colleagues, Mark Pearce has joined us and Steve McHugh has joined us, Chair.
We'll hand over to them.
Good afternoon, everybody. My name is Mark Pearce. I'm the Head of Population Health Management for the 3 CCGs. Let me just make myself visible. There we go. Thank you very much. I'm joined by my colleague this afternoon, Steve McHugh, and I think I'll also call on Mike Sands in place of Viv Robbins, who helped, of course, author this document. So it's a pleasure for me to have the opportunity to present this document to you. I think the very first thing I would want to say is that it's rather easy as you go on in your career to become a little bit jaded with national policy sometimes. And I think this has been a really positive experience for us in the NHS. I hope what you'll recognise, having read the document, is that it is genuinely a system document. We've had input. I think that we're presenting to you version 10.7. So you can tell from that that it's been through a number of iterations. I'm very grateful to a number of people whom I can see on screen today, to Janet Underwood, to Dr. Fox, to Mike and Viv from the public health team. David Williams has been involved, Faye Bayliss, Emma Jane Perkins, Sandra Taylor. We've had a succession of inputs, as you can imagine, to get to version 10.7. And I really hope that people can recognise that the Rutland voice has been strong in all of this. And I think from my point of view as the person who sort of pulled the document together, collated it, but didn't write all of it, I think the Rutland voice has been one of just challenge and really positive, creative contribution. So that's been really good. I do apologise, it's coming here in October. We had intended to bring it to the Health and Wellbeing Board in February, and that meeting was postponed. Unfortunately, I missed the bus in June, and that's why we're here today. So we haven't left Rutland last for any other reason other than a mixture of my omission and then the pandemic circumstances earlier in the year. I don't propose, Chair, to go through the entire document in any detail. I'd take the document as read. Before I invite Mike to make any comments and just bring my colleague Steve in, I do just want to highlight a couple of what I think are really important principles. So you will have noticed that the document lays out a series of universal principles or system-wide principles and lays out a series of system-wide actions. It became clear very early on as we came together from a variety of different backgrounds to discuss this, that there couldn't possibly be a system-wide strategy. So when the system encompasses areas as diverse as Rutland and inner city Leicester, each of which has in its own way different challenges around inequalities. And of course, it's not simply a matter of saying that the city has all the inequalities and Rutland has none. That's absolutely not the case. But when it comes to encompassing a region as diverse as this, and when it comes to looking at the real principles of localism in the long-term plan, it's very apparent that health and well-being boards at place level have to be the real drivers and creators of place-led plans to reduce health inequalities and lead on the implementation of those plans with the directors of adult social care and with partners, of course, from the NHS, from the voluntary sector, from other public sector organisations. So that's the first thing to say, is that this is a set of system principles and system facilitative actions, but it is for, in Rutland's case, for Rutland's Health and Wellbeing Board to work with your partners to develop a plan that works for you in terms of addressing your own particular sort of permutation of health inequalities. The next thing to say is I think I would just draw attention to a couple of the principles which I think ought to be on everybody's mind. One is around prevention, the real core principle of prevention, not just as a sort of an eternal public health interest, but in terms of trying to move us in the NSS, I think in particular, away from being what is in fact a sickness, a national sickness service or ill health service, towards being a national health service. And that enjoins all of us, I think, to cooperate, to look at what are the determinants, the wider determinants of health and the NHS controllable determinants of health. It's perfectly obvious from the literature, everybody here will be familiar with the idea that local government services in the round, and not just adult social care services, but local government services in the round, have a fundamental both commissioning and oversight function in regards to areas such as education, housing, transport, etc. And those functions are fundamentally determinative of people's long-term health and well-being, their life chances, as Rachna alluded to, from the very moment of conception, and also our ability to form a community of common cause around supporting people to be their best selves, our communities to be their most cohesive and flourishing from the cradle to the grave. So for me, this feels like a very important document, because I hope what it lays out is an opportunity for us all to cooperate ever more sort of closely on those things. I say, as somebody who's been in this country for 24 years in the NHS, I think it's a great opportunity for the NHS to learn from other partners about how we can do better in terms of prevention and true holism. The final thing I'm going to draw your attention to, which I think is worthy of discussion at some stage, is the principle of proportionate universalism. It's probably one of the most testing, if not controversial, principles within the document. So the UK offers a universal healthcare service, for example, and a number of public services which are universal and free at the point of access. A universal service doesn't mean, however, that we offer the same service to everybody. A proportionately universal service challenges all of us to make the resources we have, both financial and human and other, proportionate to the needs of the population, and to recognize that population needs vary across and within areas, geographical and within communities. So that's one of the most challenging things here is, I think, can we truly say that we're willing to perhaps challenge historical allocations, challenge the way we traditionally think of making services available, to make sure that they are proportionately universal and not simply universal. So I think that's the way in which we'll build genuine equity of access for all the services that we've been talking about this afternoon. But it does, of course, mean that we may need to think again and challenge some of the historical ways in which we've allocated services. Now, I would say within the NHS that LLR is the first system in the country to step away from the Carhill formula as a way of allocating GP funding, and to use population health management data, case mix adjustment data, and other adjustments to try and find what we think is a more equitable model of distributing primary care funding. Dr. Fox was part of that work, as were other GPs from the region. And I think we've had what I believe has been a very healthy debate. But that's just an example of where we have begun the work of looking at how we allocate resources. So, Chair, I'll stop there. I would like to, in the absence of Viv Robbins, who really was co-led this work with me, I would like to invite Mike to make any comments he thinks fruitful before I would like us to hear from my colleague Steve about the impact of levelling up and particularly as it pertains to Rutland.
Yeah, thanks, Mark. I don't think I've got an awful lot to add to what you said. Certainly from a public health point of view, you know, the principles, the focus on prevention, the focus on universal proportionate universalism, always get it the wrong way around, absolutely what I would support from a public health point of view. But I think your point about applying it to Rutland is well made. We heard at the start all the deputations and questions in relation to veterans' health, access to services, geographic inequality, and indeed relative deprivation, not just absolute, is absolutely basic. We need to use the framework and then use it, if you like, as a mirror to hold itself up to Rutland and see where we stand about it. And then coming back to the earlier point, meshing it all together and taking some action.
Thank you, Steve.
Yeah, thank you, colleagues. And it was just, it's a brief but important point, I think, in that within the document you have there, we make reference to levelling up, or you might have heard about closing the gap, which is a national debate. And that's a really important point. It's important because closing the gap can mean that you're putting a pressure on both ends. Now, what we absolutely don't want to do here is close that gap by making, by reducing the really positive outcomes that people are experiencing already and making their outcomes less positive and closing the gap that way. It's important that those experiencing really good outcomes continue to do so. And we've got to put investment in, as Mark alluded to, proportionate universalism, about investing in areas of relative need and making sure those experiencing poor outcomes, that we're able to pull them up and level the gap that way. The document also makes specific reference to a recognition of rural inequalities, and that's already been discussed in this meeting. That's really important, so that it's absolutely acknowledged that, you know, in Rutland, there are areas of focus that we need to put attention, resources into in terms of reducing health inequalities, and not in at least to our retired and active armed forces personnel, but also about specific geographies that we will be aware of through the data that we need to work together with our partners. And then the final point I'd like to make, whilst this document has received really positive reviews and feedback at a regional level, that's only the start of this journey, isn't it? Because this is a strategic document, a framework, therefore, to produce the actions that are going to happen at place and even in our neighbourhoods. And that's where the real stuff gets done. So it's really important that this document is seen as such. It's a strategic document to then develop future actions within our neighbourhoods, within our places, that really impact on reducing health inequalities. Thank you, Mark.
Thank you very much, Steve. I think that's all we've got for the moment. We're very happy to take questions on anything.
Yeah, thanks very much for that. So David Wilby's first.
Thanks, Chair. Steve, I think your comments at the end really helped me, because I'm just a simple aircrew mate who read through this, and I read through it about twice, and I found some of the facts were being obscured really by the verbology, you know, the words around them sometimes, and it made it more difficult for me to really find the meat of the substance. But I think your statement at the end, which says, okay, this is a strategic document which lays out the detail and then tells you in infinite detail exactly how you're going to achieve each of those principles. And if you use that as your guidance Bible, that will help you determine later on the actions required to get it and actually reach the target that you're going. Because I read it, and as I say, I read it twice, and I thought, you know, what I'm not seeing is how we're going to achieve all these things and where the action is. And I think your explanation right at the end there has helped me, because it's not an action document, it's a way of telling you how to get those actions done and what actions are required. There was one other little point I picked up, and probably not right to say it, but in the discussion there about using the equipment for the diabetics and things like that, there was this question of it wasn't so easy for non-English speakers to operate the equipment. And I know that you are far more, it's more difficult in Leicester and Leicestershire and Leicester City, because you have a large population of folk who come from all over the place compared to us in Rutland. But I do think that we need to make sure nationally that everyone who comes to the country really has to concentrate to speak English so they can, you know, fully integrate into the system. Just a byproduct, as I thought. But thank you very much for the paper.
Thanks. I'll move swiftly on to Dr. Fox.
Thank you. Thank you very much for the paper, Mark, and fully welcome the emphasis on prevention. Obviously, today's prevention is tomorrow's reduction in health and social care needs. How do we make sure that we don't lose the people within the statistics? How do we make sure that we have got enough of the personalised information that gets lost within the data? So our affluent population, as we know, has a small number of people who are living in deprivation. We have a food bank, but if we're concentrating on the data, then we may lose those people, and we just may not be able to see them. How are we going to make sure that this framework actually has enough personalisation and enough individuals represented in it, so that those communities who aren't counted, you know, those communities who don't appear in statistics are actually having their needs met? And just on that, the military population have a separate primary care service, so they don't fall under our primary care network. Their primary care service is not represented in this group. Where we've got developments and improvements that are being made at primary care level, how are we making sure that that happens, and that is to those people living in military populations who are under the care of military primary care services? I think that's a national issue, but we need to make sure that we're addressing it here.
Thank you, Dr. Fox. I certainly agree with the second one. I think that is a national issue. It is something that we need to keep an eye on, and I would look to our colleagues in public health, excuse me, to help make sure that that conversation at national level, the outcomes of that conversation at national level, are reflected here locally. I think your other question is at the very heart of a lot of population health management, to be honest. How do we toggle between the insights and understanding that large data sets can give us, but yet find a way to find the human in all of that and the individual? And this is where I think, for me, it was very useful to realise the benefit to the NHS of collaborating with local authority colleagues or voluntary sector colleagues who very often have access to intelligence and understanding about communities, which is not necessarily data rich, but is certainly very rich in an understanding of how life plays out for individuals and small communities. So I think it can only be to our benefit in the NHS to keep our ears open and to keep open seats at the table, to listen to those voices who say, look, I'm sure this doesn't appear on any of your reports or graphs, but there is a problem here, or I met an individual yesterday who has this issue. So I think the good news is the population health management at its best will be able to accommodate both qualitative and quantitative data. I'm really hoping we can become the kind of partners, we as the NHS can become the kind of partners for local government and the voluntary and community sectors, and fire and rescue, for example, and local community policing, who very often have additional, very rich insights. And we need to be prepared to listen to those and find ways of acting on them.
Thank you. I see no other hands raised. I do have an observation, or possibly two. So Dr. Fox talked about an affluent population. Let me just say that, speaking as someone who lives in the middle of a social housing estate, I don't see much affluence anywhere near where I live, and there are many people living very different lives to the ones who often come forward and shout loudest. But of course, it isn't just urban areas that suffer that. We have very asset-rich, cash-poor people living out in the villages. And I was watching the Andrew Marr show. I'm lying, I was listening to it while reading on Sunday, and my ears pricked up when I heard that Andy Burnham was on there complaining about levelling up. He was complaining it's £1.50 to get anywhere in London on a bus, but it's £4.50 in Manchester, and how unfair that was. To which my answer quietly to myself was, well, at least you've got a bus that you can pay £4.50 to get on. So if that reassures those people who spoke with their questions and deputations earlier that we do understand what you're talking about, then I hope that goes some way. So my issue is, how do we balance the strategic with the needs of the individual, and how in practice are we going to find some of these solutions? Because I don't believe there are any simple solutions, but I do appreciate the paper and I welcome it, but I just want to see how we actually do it in practice. I don't see any other hands going up. So is everyone quiet on this one now, and we'll carry on? And I have lost my screen, Jane. Are we on to the local plan?
Yes, we are. So we have a joint report and presentation from the council, the clinical commissioning groups, Public Health and Rutland Health Watch regarding the development of the Rutland Health and Wellbeing Strategy, a plan for place. So I think it's first, here we are, presentation. Thank you.
Thank you.
Okay, thank you. I'm not sure who's sharing that now. I was about to share it, but somebody else has put it up. Okay, so I just want to go through a presentation, and myself and a couple of my colleagues will walk us through this. You have had the plan as part of your pack and the paper that went with it, but we thought it was quite important to try and sort of just go through and actually update you on what the plan was all about, and hopefully discuss and open for questions on it. So obviously the purpose of bringing this to you, as you've seen in terms of the other presentations that have been presented this afternoon to us, this is another piece of the jigsaw. So we want to bring to the Health and Wellbeing Board something that is very much localised. So what we've been hearing with the other presentations are some of the national sort of plans, some of the Leicestershire County, City and Rutland plans. And what we really want to focus on with the plan that we're presenting to you this afternoon is actually our own place-led plan. So what does this mean for Rutland? And to suggest from the research that we've been doing some of the priorities that we have identified as part of the plan, and also how frequent we're going to, I know one of the questions that you said to Rachna was, how frequent are we going to progress the reporting on this? And also, what does that look like? So next slide, please. So just to put that context into a little bit more description, what you heard earlier from Rachna is the integrated care system, the local, the LLR, purpose, principles and priorities of transforming the existing systems into that integrated care system. What we're presenting to you today is a part of that wider picture, making it more localised. So what does that mean for Rutland? Rutland is a place, and very conveniently, we're also what we're termed as a neighbourhood. So that is within our GP practices, forming a primary care network integrated with social care and all of our partners in our voluntary sector as well. So our place-led plan is collaborative.
It is across health and social care. It is about looking at the data, looking at the population health management data, but also working with our people in Health Watch and looking at the Rutland conversation that we've had to find out what our public actually are saying to us. We've had lots of questions and deputation today, and it's about listening to what people on the ground are telling us, what the access to services is like, and what we can do in terms of prevention. As Dr. Fox has just said to us, today's prevention is tomorrow's reduction in access to those services. So we need to bring all of that together, looking at that lovely framework that we've just had the presentation on about those health inequalities, looking at the strategic aspect of that document and bringing it down into this place-led plan about what actions do we need to do in order to make that happen. Next slide, please. So place is really important. It is our building block for that health and care integration within Rutland. And when we look at the national ask for what that means for each place, it is about making sure that people can stay well, that we have access to those preventative services, that it's simple, that it's easy to join up the treatment where it is needed, looking at other options to access services through our digital alternatives, putting people at the heart of their own care. And that isn't necessarily making things accessible for everybody to provide a service to, but also encouraging people to have their own self-care and self-management. Proactive support to keep people as well as healthy as possible, but also identifying where the vulnerable people are and at high risk. Making sure that we expect the NHS to play a full part in the social and economic development and environmental sustainability. So it isn't just about health services in isolation, but it is also about that wider employment, training, procurement, volunteering aspects as well. Next slide, please. So what we needed to do when we brought this plan to you is to make sure that we build on the local strategic visioning work that we've done to date. So yes, we had a JSNA that was in preparation and being reviewed in 2018, but we understand that the pandemic has caused a pause to some of the work and that we needed to reinvigorate that going forward. We need to make sure that there is that collaborative partnership working, that we've got the intelligence, we've got the prevention, we've got complex care aspects all mixed into all of this. Intelligence, as I say, is not just about the data. We need to make sure that the JSNA, the public health options outcomes framework, and all the indications of health management data are put alongside things like the Health Watch, What Matters to Me, the Future Rutland Conversation, the CCG's engagement triangulation that's been done. We need to have some wider sources of information. Some of those have been produced for Rutland for the first time. Historically, in the past, a lot of our data has been linked in with county, and to get the actual data right down to Rutland residents has been quite difficult, but we've worked really hard on that. We want to make sure that the outcomes that this plan is actually encouraging is overarching visions and strategic actions, that we've got that collaboration and delivery of the actions that we come out with, that they have the greatest impact for our citizens within Rutland, and that we monitor those outcomes and the delivery of the plan, continually engaging and checking back with our residents, that they can see that if we say we're going to do something, we've done it, and has it had a difference? Next slide, please. So the evidence base that we have actually been looking at has been wide, and this slide, although is very small and might be difficult for you to understand, what I really want to emphasize to you as a result of this slide is we haven't just looked at one specific area of data or one specific consultation that we've done. We've engaged throughout a lot of documents, a lot of consultations, and brought them all together within this plan. So next slide, please. So what we've done within the plan is to summarise the priorities and principles into hopefully 5 priorities. Now these priorities are independent and are integrated within each other. Not one of these priorities takes precedence over the other. They are equal in terms of what we want to do within them. There are things that will happen in one priority that might integrate into another one. But ultimately, the goal is that people are going to be living well and active within our community of Rutland. We want them to be safe, healthy, happy, and have caring communities where people start well, thrive together throughout their lives. And what I'd like to do now is invite Mike to actually walk us through some of those priorities. So next slide, please.
Yeah, thanks, Emma Jane. So some of this might look reasonably familiar because if you've sat through Rachna's presentation, you'll see that, as you might expect, really, if you take a life course approach, the overall things that are keys for the health of Leicester City and Rutland are going to be the same if you concentrate on Rutland. So essential priority one, best start in life, evidence-based nationally and locally, does suggest the importance of the first 1,001 days of life. Core principle is about using that window of opportunity to meet the needs of the baby from preconception through to early years, two-year-old, including key action areas designed to make things easier for parents and carers. Numbers of focus for action within the local plan. So health outcomes for children under 2, things like breastfeeding and under 5s. SEND, special educational needs and disability, access to preventative services, including vaccination, tooth decay, which, if you remember, Rutland didn't have as good outcomes for as as you might expect, and obesity, and building self-reliance, self-resilience, and emotional well-being in younger people. And all of that was triangulated by what Rutland residents say. So that's priority one, best start in life. On to the next slide, 2, as you might expect from a public health person, staying healthy and independent for as long as possible. So again, we've spoken throughout the afternoon about the importance of prevention, but for me, that's also about self-care and self-efficacy, and maintaining independence has been critical to improving life expectancy whilst managing increasing demand within a defined health and care budget. And if I just not draw offence, but as Hilary said, well, just to correct Hilary, I think I'd be happy if we choke off the increase in demand through prevention. I'm not quite certain we can deliver a reduction, but prevention is the way that we're going to keep a lid on the cost of increasing the elder population. And again, as Mark said, we need to shift our approach to one where prevention and self-care is key to what we do. Within that, in terms of focus of areas for action within the plan, there is something for me about enabling the whole of Rutland to be active, so enabling active local communities. Cheers. And also then concentrating our efforts on those that are most at risk, so those that are more likely to fall, those that are frail, those that have got 5 or more comorbidities, the population health management stuff that Mark talked about earlier. Few comments from Rutland residents which we need to bear in mind, particularly around access to services, and do we need to pull those awareness of what is out there into one place, and the other bits that you can see mentioned on the bullet points there. And then lastly from me, 3 is about reducing health inequalities. And again, don't need to say so much on that one because I think we've well covered that in relation to the previous one. We've talked about the health inequalities framework across LLR, but for me, that's about then refining it down and being led by local intelligence. So where we've covered the relative deprivation issue that Councillor Walters raised, the health of particular issues like veterans and armed forces in Rutland, I think we've sort of well covered that one. So nice to see that the previous 2 or 3 presentations have reflected those key points within the plan. And I think, Imogen, if I got it wrong, am I going through all 5, or is it somebody else picking up these?
No, so Joe's going to pick up the last 2 priorities for us. Thank you. Over to Joe.
Thank you both. So potential priority 4 is all around equitable access to service for all Rutland residents. And why? Because we know that Rutland is a rural county that borders a number of other local authorities and healthcare systems. And we know that living on the boundaries can present extra complexities and unequal access. And I'd say this one has really been driven by what Rutland residents have said. They said that they want to see an increase in improvement in local health services at place so that travel could be reduced. And they want to see more straightforward and routine diagnostics and treatments to be available to them closer to home. And of course, they've told us that not everyone has access to technology or the necessary skills. So they want to see an increase of the use of technology with careful consideration of how and when to use it effectively. So the real focus areas for us is around that consideration of what services can be delivered within Rutland. So we absolutely need to be looking at data both in and out of area and looking at where Rutland residents are going and what they're going for, and then working with our primary, secondary and tertiary providers about what realistically we can provide back in Rutland and that care closer to home offer. Next slide, please. And last but not least, our potential priority 5 is all around preparing for population growth. So we know that the overall population of Rutland is projected to grow quite substantially in the next 20 years, with considerable growth in that 65 plus age bracket. So that we know we've got to look at making sure that that future impact across health and care, it's sustainable and that we get a fit for purpose offer. So we need to look at capacity, we need to look at workforce, we need to look at estate, what that health and care model should look like. And of course, that all important cross-boundary issue. So we need to look at that neighbouring population demands on local service models and take that into account for local planning.
Thanks, Jo. Next slide. So what we want to do is, you've had the plan, it's with the papers, Chair, and what we would like is some sort of refinement of that plan during the next couple of months from October through to December. We would love to have dialogue across our partners, across our public and with our stakeholders during that period of time, October, November, December. We would love to, if we are in agreement that the principles and the strategy that we are putting forward looks like it might cover quite a lot, but is in the right direction. What we would like to do is obviously define a more detailed delivery plan. You know, what actions are we going to do? We've decided that these are the priorities maybe that we want to focus on, but you know, who are going to be the lead partners? What's the rationale? What's the time scale? And ultimately, what is our measurement of success? What outcomes are we trying to achieve? We'd like to propose some public consultation on the strategy to take place in November and December, with a final strategy with that draft delivery plan very articulated with it, and to present it to the Health and Wellbeing Board in January, so that we can start to operationalise that plan for delivery from April 2022, which is when our integrated care system really comes into place. Next slide, please. So we are looking for recommendation that the Health and Wellbeing Board note the content for and the progress towards the development of this strategy, and ultimately with it the plan for the place, which is for the 3 years from 2022 to 2025. We'd love you to discuss, agree and endorse the overall visions, principles and priorities and action areas set out in this draft strategy and plan. We'd like you to confirm proposals for the public consultation and authorise the integrated delivery group, which is the subgroup of the Health and Wellbeing Board, to run that public consultation on this draft strategy. We'd like you to agree the frequency of reporting of the performance of the action plan going forward once it's been agreed, hopefully in January, and approve the timetable I've just described for finalisation of this strategy. Thank you, Chair.
Thank you for that, everyone who contributed. Obviously, there are a number of areas that you're asking us to look at. Can I suggest that we first ask if there are any questions or comments on the first 2 items? So it's essentially the vision, principles, priorities and action areas in the draft strategy. Can we look at those first before thinking about consultation or feedback or anything of that nature? So are there any comments or questions on the vision, principles, priorities and action areas? And I'm looking and I see no hands at the moment. Don't be shy. Right. Shall we let Mike go first and then it's John?
Yeah, thank you. In danger of challenging my own strategy in part. Obviously, we've just been through it, not going to disagree with starting well, staying independent and supporting people the one that normally gets involved in a life course strategy would be dying well. So we've got those cross-cutting themes of reducing health inequalities. I guess personally, and I suppose maybe on behalf of people in Rutland, there'll be a few people who say, well, what about end of life care? And I suppose it's worthwhile just asking where we pick up those actions as we go along.
Yeah, I couldn't agree more. John?
Yeah, yes, thank you, Chair. I guess I was hoping to get there before Mike, but that rarely happens. I just wanted to make a general comment. We've been using the word working together a great deal here. And I just wanted to thank all of the staff, officers, NHS, third sector, that have put this together. They've put it together at a time of great stress on their own services while doing this. And it's very easy for us to sit around that aren't fighting on the front lines, but that has actually happened. And my thanks on behalf of the council for all your hard work in actually doing this, and just to recognise that. And I also wanted to say, if I may, Chair, that in Rutland, we've prided ourselves in the last 4 or 5 years on working closely together with the very people that sit here with us. The fact that we're sitting here in this way is testimony to that. And all of us who have been presenting have used the word working together, partnership, collaboration. And we have a very, very good foundation for doing that. And I personally endorse everything that I've been hearing, and as always, want to get on with it. Look what we've achieved in the last 18 months, and we can absolutely, together we've vaccinated the population. We've worked together with care homes to keep them safe. In the early part of the pandemic, we were sourcing our own PPE and distributing it. We've been shielding the vulnerable, supplying food, medication. We've enabled good flow to the hospitals. We've set up COVID sites. And these are things that we now need to build upon, and indeed, I think, are building on. It was good to hear of the plethora of up-to-date data, both qualitative and quantitative, that has informed this. I think that's very important going forward. It needs to be Rutland specific, and I know that it is Rutland specific. And just to use a word that Rachna used earlier, actually, I don't know if it's the exact word, but this needs to be a living document. It needs to be dynamic. It needs to respond to people's needs. As that data changes, it's no good being stuck to one piece of paper that sits there on a shelf and is wheeled out once a year. As soon as we know something, it needs to come here, officers and partners, we need to change it, act upon it, because it's our public that must be the centre of this. And I'll leave it there because I need to come off my soapbox.
Well said, John. Janet Underwood.
Thank you, Chair. I think the thing that I've taken from this document very much, and I've also been considering comments that have come into my email inbox. People have asked earlier on, where is the plan? This is not a plan. To me, this is sort of an overall strategy. It's the what, and the how and when is going to follow. And I think this needs to be made clear to the public when you go out to consultation, that this is the what of it, the how and when will come in due course. And following on from that, I'm sort of thinking there's a heck of a lot of work to do the how and when in 3 months. Is that achievable? It just seems a phenomenal amount of work to me, but who am I to say? And I'm not quite sure whether the comments I'm raising actually refer to the whole thing or to sections 1 and 2, but going through to sort of public engagement, I think it's really, really important that the public are taken on this journey as well, and that public engagement isn't just for 6 weeks from sort of October to December, but that it's at each and every stage. People told us quite firmly when we were doing the engagement for the What Matters to You project that they want to be involved, they want to know what's going on, they want their voices heard. So can I encourage public engagement, active public engagement, and listening to people's voices throughout the process, please? Thank you. I'll get off my soapbox now.
Yeah, I think that's perfectly fair, Janet, and no one else has their hands raised on the first two items, so you've led nicely into the consultation. I know that the Rutland conversation did go down very well, but that again must not be a one-off, it must be a continuous process. So we're going to move on to the public consultation and reporting. I have a slight amendment to suggest to number 3, just to make sure that the voice of members of the council is heard on this. So the integrated delivery group to run the public consultation, could that design of that be made in consultation with the chair of this board, please? So I see what's going on before it happens, if everyone's happy with that. So any comments on the remaining 3 then, the public consultation, frequency of reporting and the timetable? Hilary, you're first.
Just we're in a phase of quite considerable social change and particularly health change at the moment. We are still in the middle of a pandemic. It's not gone away, and actually setting the priorities for 3 years at this point, there needs to be the flexibility to respond to what we're going through at the moment, and so when we're setting the dates of how we're going to develop the development plan, again, it needs to be a fluid and living document, and it needs to be a fluid and living plan that responds to the feedback that we get from patients and people living in our communities on an ongoing basis. So I think those finishing dates need to be transitions rather than finishing dates. I appreciate we have to have some sort of deadlines, but I think we need to have and then what next in there as well.
Yeah, that's wise words. Is there anyone else who wants to come in? Janet, are you coming back?
Yeah, if I may. I just wanted to sort of add something that I don't know whether it should be included or not. I just wanted to throw it out there. And I'm happy to be trodden on and shut up. But what I'm picking up, both from providers of care, commissioners of care and the general public, is there seems to be a lack of confidence in the public about caring for their loved ones or caring for themselves. And to me, this comes back to health literacy. And I'm just wondering whether some principle or something about increasing health literacy or confidence in the ability to care or knowing how to care should be something that could be included somewhere along the line. But that's just me thinking that.
Rachna?
Thank you, Chair. So, Jenna, it's absolutely not just you thinking that. That's come through loud and clear from some of our parent groups across the patch, as well as some of our caring groups, effectively, who care for perhaps parents and the generation who needs the care that we're giving at the moment. So I think it's a key plank, actually, of our strategy, and it absolutely needs to be in one of those life course events, or in every life course event, in my opinion. And I think Mike and I have had that discussion many times, as we have with Ivan in the city, about how we make that happen and make it very real and make it right for the community, recognising that not every community will need the same level of either intensity or they will need different things. So this comes back to working with communities to identify what it is that they want specifically, and then us coming together as a health and social care collaborative, and then figuring out how we're going to deliver it, quite frankly. So I think you're absolutely right. It needs to be a key plank, but it needs to be right for those communities. So just writing a blanket statement in the strategy is not going to work. We need to work with those individual communities to understand what they need and how they want it best delivered.
Is there anybody else? So my take from that is Janet's last comment will be incorporated really within the actions or priorities as written. But is there a general understanding that dying well needs its own section now? Is that what we're saying? Is anyone saying yes or no in particular? Mike?
Open to debate on that one. Having suggested it, equally the downside is, you know, sticking to 5 priorities is, you know, feels about the right number. So I'll be guided by colleagues, but there's a question of whether it needs its own section or whether it becomes a subset of supporting to live independently or some such. I've looked at people who know kind of end of life care better than me to say whether it really needs its own special section or whether it just needs kind of beefing up in other bits.
I have my own thoughts, but I should listen to you guys really as professionals. My thought is if we've got the first so many days, then there's nothing wrong with having a section at the other end as well. But Rachna, what were you thinking?
So Chair, I'm not clinical, but I would certainly advocate an approach that takes that exactly as you said. We need to focus on the last 1001 days. It's a harrowing experience for our carers and our families, and quite often leaves residual issues within the family. So I think we should take it as a standalone if we get the support of the board today.
Yeah. Janet, do you want to come in? I saw someone else, but their hand disappeared. But Janet.
Yeah, I have looked after people who are dying. I've looked after people in their own homes, in hospitals and in care homes. Not recently, obviously, but in my sort of working life. I think it's very important that the care that these people receive at their end of life, and it's going to affect all of us after all, I think the care should be appropriate, sensitive, and exactly what is needed, and with a focus, and also for the family afterwards, as Rachna says. So I think it would be better to have a section on that. My problem is that whereas you can mark the first 1001 days of life from birth, I have known people who've been told that they're going to be dying and they're probably going to be dead next year, and they live for another 4 or 5 years. Conversely, some people think that they're going to live forever, and they suddenly have a massive health crisis, and they're facing death within a few weeks. So I'm not quite sure how you're going to phase it as 1001 days at the end of life.
No, I think that probably needs rewording in some way, doesn't it? But my gut feeling, which I shouldn't go on, but my gut feeling, it feels right to have this as a separate section. But John, you had your hand raised next.
Yeah, it's an important point, actually. You know, we're not very good in this country at discussing this subject, and it is something that comes to all of us. It's an inevitability. It's full of fear, full of dread to most. Some people welcome it. But this is part of the story of life. And if we're having the first 1001 days, it makes absolute sense that we have the last time on wherever you think you are, you know, and be open about that, but use it also as a catalyst to get people to talk about it. Yeah, yes, I think it's an important thing that we should include.
Right, we'll go on to Dr. Fox.
Yeah, absolutely. I think putting a time frame is probably doesn't take into account the sort of diversity of end of life experience for people. We will have the work of the medical examiner coming on board in the next few months or years, and that will give us a really rich retrospective audit of end of life in the community, as it does at the moment for hospitals. We also have some real expertise in Rutland and with Dying Matters in Rutland, and some of the work that's been done, and particularly some of the integrated work that's been done with the social care in Rutland. We have the potential to be an exemplar for good end of life care, and we should certainly include that as being in our plan and our aspiration, and we should tap into those real expert resources that we have access to to improve things for people.
Yeah, thanks for that. Could we move on to, it's a bit of a technical point, but it's important, frequency of reporting of the performance of the action plan to the Health and Wellbeing Board. Now, given that we meet every 3 months, I see no reason why we don't see it at every board, but does anyone have an opinion on that? John's nodding, I see. Right, I don't see. Does anyone else have anything substantive to say before we try to sum that up a little bit? Which might not be that easy. So we're approving the vision, principles, priorities and action areas, but we're asking for dying well or a similar name to be added to it as its own section. There's a bit there about the confidence of people, which I think it was Janet that raised, that we're going to build into it. We're going to go out to public consultation, but I would like to be part of that if everyone is happy with that. We will have performance reporting at every one of our meetings. And I take it we approve the timetable, but we're mindful of the problems that we face still with the pandemic that still exists, and also not boxing ourselves in with solutions that might not be appropriate in a short period of time. So is everyone happy with that? And have I missed anything significant, or are we about there? I still see no hands, so I don't know how I managed that one then. Right, so the review of the forward plan is the next item. So the proposed agenda items for the next meeting are the final, in brackets, question mark, Rutland Health and Wellbeing place-led plan, including the draft delivery. So we've just covered that one off. Social care white paper update, better care fund update, and the pharmaceutical needs assessment, if that is ready. So does anyone have any suggestions for anything else that we should be taking? Oh, a whole host of hands. Governance probably wants to tell me it's 4 o'clock. No, you've got something else to tell me.
I do have something else to tell you,
Something
Chair.
else then, Jane, yeah.
Well, I've just been notified today that on the next agenda as well, there will be Armed Forces Covenant legislation and the impact of health provision from Karen Kibble-White.
It amazes me how everything we're talking about is tying back to the deputations and questions that we had. And I do hope that reassures people who are listening in. John, you wanted to come in as well.
Yes, Chair. It was just to make that point. I was having this conversation with Karen yesterday, and the new Armed Forces Covenant legislation is being published, we believe, later on in the year. And of course, it needs to be embedded across all our services. And so it will be very good to have it here. The other one would be a suggestion. We have a new public health offer in Rutland now, and I know Viv Robbins has prepared a paper which we took to SMT. It might be nice if she was to bring that here, if you're in agreement, Mike, and explain the exciting new offer that we have and how it's going to work for us and with us.
Yeah, good thinking, John. I mean, partly, if nothing else, actually, it's a good offer, but of course, it's not just about RCC. It will be relevant across the whole of the partnership.
Okay, I'm happy with that, but we'll have to be mindful of how much we put onto this meeting, because the place-led plan is going to have to take priority. But yeah, I take your point. Janet, you had a comment, I think.
Yes, thank you. It's just a thought, but because it's been raised so frequently across the county for so long, I'm just wondering whether we couldn't have some sort of paper delivered on what the changes to the transport infrastructure for accessing healthcare might look like. I understand there's a new bus strategy coming out at some point, and it would be really nice to see if we could have something that would actually show some movement towards getting to and from Peterborough or Leicester, especially from the villages, is easier.
I'll have a word with my colleagues on Cabinet and with senior management. My suspicion is that that will be too early for us to bring it, but that we need to put it on the forward plan, Jane, for something. It might be the one after that. But it's a point well made. And again, goes back to the questions at the start. Now, Hilary, and then we probably need to start wrapping it up, but Hilary.
Sorry, I mean, it may not be the right forum, but in view of the amount of concern that's been expressed about diagnostics and travel and so forth, and the plans that the CCG are making for community diagnostic hubs, I wonder whether that will be something that we should be discussing at Health and Wellbeing Board.
Rachna, is that integral in what we're looking at in our local place-based plan?
It is, Chair, but we're hoping to get something up and running fairly quickly. So actually, we could bring a brief update just to keep members up to date if that suits.
And again, that might be reassuring to residents who are asking. Yeah. Right. I'll just double check. I think we'll call it there. Otherwise, we will never get through the next meeting. I've not been notified of any urgent items of business, so there's no extra.
None, Chair.
The date of the next meeting, Jane?
Is Tuesday, the 11th of January, 2022 at 2 p.m. and it will be decided nearer the time if the meeting will be held in person or virtually via Zoom, but everybody will be notified.
Thank you. Before I close the meeting, I'm sure David would echo these thoughts. My thanks and praise to everyone involved who has worked so hard on the projects that we've discussed today. I'm constantly in awe that so much can be achieved in the middle of a pandemic. So thank you to all of you. And there being no further business, I declare the meeting closed at, I think it's 4:08. And thank you.
It is 18 minutes. Thank you, Chair.
Thank you. Bye-bye all.
Thank you.